I'm Megan Tollefson. I'm here at Mayo. I've appreciated being able to be a part of this group and this meeting for many years now. It's always just a wonderful group of people to be together with and to learn from. I am a pediatric dermatologist, for those of you who haven't met me before, and help to lead our malformations clinic and program. I've got a number of great colleagues here who, some of them you might not know, some of them you do know. And so the first speaker especially, actually before we move on to the speakers, if you did want CME credit for this, Melanie has packets in the back, so please pick them up. And then you can return the paperwork to me or to her. So our first speaker really doesn't need much of an introduction in this group, Denise Adams, who couldn't be here in person with us, but the one of the positives of the pandemic is that we've been able to figure out how to do this not in person as well. So she has graciously agreed to be on Zoom here with us, and as you all probably know, Denise Adams is a professor of pediatrics and director of the Complicated Vascular Anomalies program at CHOP, but more importantly, just an innovator and advocate, brilliant and amazing physician and friend to many people in this room and across the country and the world. So I will let her take over, share her screen. Denise?
Great. So thank you, Mega. Again, very sorry that I'm not able to be with you today, and I hope that you all enjoy yourself and have fun, just like Mega said. I particularly hope that you think of me and dance the night away tonight. So, so today I'm going to talk a bit about what we call phenotype-genotype correlation of disease. And I'm also going to talk a little bit about new medical therapies that you all have heard a bit about during our last couple of meetings. And I want to give you the perspective of how it is for a vascular anomalist, and a vascular anomalist is any specialist that takes care of vascular anomalies, because it's not as easy as it seems when a patient comes to see us. And so I want you to feel a little bit about what we think about and sometimes really struggle with when a patient comes in to see us. So I have worked for some of these or consulted with some of these drug companies. So these are my disclosures. And most, now my slide from 2 years ago said all drugs, but most drugs are off-label, which means that they haven't been approved by the FDA. And so we're going to talk a little bit about what a vascular anomalist is. We know a little bit about the classification, but we'll talk just a little about that. I want to talk with you about what I think a phenotype is and what a phenotype is as a clinician deals with patients, and then what a genotype is and why sometimes it isn't always so easy as that, so we can't put things into nice perfect boxes like we would like. We're going to talk a little bit about clinical trials and drugs, and then thoughts for the future. And so a long time ago, when I got into vascular anomalies, there were many different kinds of physicians and actually nurses and PTs and other specialists that were taking care of vascular anomalies. And there became, over time, what John Mulligan from Boston used to say, of people who had the gene for vascular anomalies, people who really wanted to find out the whys and take care of patients. And those are the people who I call vascular anomalists. So early on, 30 years ago, and it's hard to believe, I used to say 25 years ago, but actually someone corrected me and said, you've been doing this for 30 years. So it used to be that we just looked at pattern recognition, like what was similar, what was not. And then a very simple classification system was developed, and a lot of you all, some of you that are older, were treated by surgeons and by interventionalists who were doing their best to take care of patients. But there was very little medical options. There were very little medical specialists who got involved. I think the dermatologists were really the first, what I consider a medical specialty, that got involved in the care of vascular anomalies. There were no clinical trials. There were no groups that were in charge of any clinical trials. And now We have a wonderful classification system. We have some standards of practice. We have these multidisciplinary centers that have popped up, larger centers, middle of the road centers, and even smaller centers that are out there now. And that's really important because we have to get that appropriate care to you. We have medical therapies. We have something that I'm going to call phenotypes and genotypes and clinical trials. And we also have some biomarkers, which are things that you can look at in the blood or other areas that might tell us a little bit about your vascular malformation. So as you all know, a long time ago, John Mulliken and another physician got together and called vascular anomalies either tumors because they were growing or malformations, and broke those down into those that are low flow, like venous, or lymphatic, or high flow, like arterial. But it's much, much more complicated than that. We know that there's a group called the International Society for the Study of Vascular Anomalies. And in 2014, with the help of a wonderful pathologist and also people like Fran Bly, who you all know, got together and really came up with a much better classification system. And this really honed into what tumors were and what malformations were. And then this was new diagnoses were noted, anatomical variants were noted, some new syndromes were named. And then there also became some acceptable genetic causes of vascular anomalies. And this was updated again in 2018 at that same meeting in ISFA. And at the last meeting in Vancouver in ISFA, we started to talk about revamping this classification as well, almost to make it now a little simpler. So before I jump to that, sorry, I jumped to that too quickly. I know you all had lunch, and I am going to show you some pictures, and some of the pictures are not so great, but the pictures are important because the pictures show you how different vascular anomalies are. So even though people might have the same diagnosis, even though when we start talking about genetics, and you're going to hear from the geneticist at Mayo later on, even though people have the same two things, they can look so different. And that's why it always isn't as easy as one thinks to make a diagnosis and to figure out a plan. So these are all pictures of tumors. And many of these tumors are the same diagnosis. This is an infantile hemangioma. Hope you can see my pointer. This is an infantile hemangioma. This is actually diffuse liver lesions that are an infantile hemangioma. This is not an infantile hemangioma, but this is something called a congenital hemangioma. And these two things here are tumors. This is something called a KHE tumor, and this is something called a lymphangiosarcoma. But you see, there's a lot of heterogeneity. How can these all be the same thing? And how can we treat them the same way? We know that we sometimes can treat them the same way, but we have to think about different risks for these patients depending on how they present. These are pictures of vascular malformations. These vascular malformations are all different, but this and this and this and this have the same somatic mutation. So these are all PIK3CA positive. They are a little different with their diagnoses because this is a macro and a microcystic lymphatic malformation. This is a microcystic lymphatic malformation. This is something called Clove syndrome without really any vascular problem except for some ectatic veins. And this is someone that has a capillary lymphatic venous malformation. This also was thought to be PIK3CA, but this is a lymphatic malformation, just like these are lymphatic malformations, but this is caused by a different somatic mutation. And these two are venous malformations, and you can see how totally different they are, but they have the same causative somatic mutation being TIE2 or TEC. So you see, again, the heterogeneity, the complexity of the patients that we take care of. And this up here is a capillary malformation that over time has proliferated and has these things called pyogenic granulomas. So the whole theory a long time ago saying that vascular malformations don't proliferate is really not correct. So these are imaging features, and you see again the heterogeneity of the imaging features. This is a diffuse lesion, which winds up being a venous malformation. This is a lymphatic malformation, which is very localized. And these are very complicated lymphatic malformations that have the same somatic mutation, and these both are tumors that have different somatic mutations. So very different with what we see, very different as well with what we see under the microscope and also with radiology. Again, this is what you see under the microscope, and you see that these are tumors that have different linings of their endothelium. These are malformations, but this is a malformation that one might think, because of how big the muscle layer is, that it actually is an artery, but it winds up being a vein. So important to note that not everyone is the same, but more important to note that because the pathology and the radiology and the physical exam are so different, it really requires that we have people with expertise in all of those areas taking care of vascular anomalies. And that's who we are. We are vascular anomalists, and that's really important for you all. And so when we think of our teams, what is the dilemma that a lot of times we have with our vascular anomaly teams? And our process is usually this. So when we get a patient that is referred to our clinic, a lot of times in the 3 different places that I've worked, we say, we need some history, we want a picture, because we have to think about a bunch of questions when a patient just comes in. Why is the patient being referred to our center? What are the patient's symptoms? What are the parents and the patient's concerns? Then when we look deeper, what are the tissues and the vessels that are involved? What do the imaging studies show? Or if we don't have any, what imaging studies should be considered? And then before we even see the patient, we think about, okay, so what do we think the probable diagnosis is? And if we think about that, and if we have a picture of the patient and maybe we review the radiology, what are the risks that we have to worry about for this patient? Not only the risks that are happening right now, but also the future risks. And then what kind of intervention needs to be considered? Is it surgical? Is it interventional? Is it medical? Is it combined? Or is it just observation? So just to give you a sense of what we all think of when a patient comes to see us. And so this is a patient that we have a picture of. And so when we think about this, why is the patient coming to our center? Coming to our center because there's weeping from these vessels, these vesicles that are on the skin. There's some pain, and those are the symptoms. And they're coming to the center because the patient wants a second opinion, or the patient has heard of us and lives in the area and wants to come to a comprehensive program. What are the parents' concerns? They really want the right diagnosis. They perhaps have been to multiple centers and have not gotten an answer for what the diagnosis is. And then our issue is, what is the diagnosis? We see that on this picture, so this is before we even touch and feel the patient, that this patient has a capillary malformation with these vesicles. So we presume there's probably a lymphatic malformation that's also involved. And we can see from the pictures that there might be some dilated veins, because you see this area that's a little bit larger or poofed out in this area. We also notice from this picture that this leg is involved, but the other leg is involved too. And we also note that perhaps these fingers are a little bit bigger. We don't see the other fingers on the other hand. We don't really have good pictures of the feet, but these are the first things that we're thinking about when we see this patient. And so we consider, so we went over the vessels that we think are involved. We think about what imaging studies do we need? Well, what imaging studies has the patient had already? And we want to see those. If the patient hasn't had them already, do we need to get an MRI? Or do we need to just see them first and make that decision afterwards? And what's the present risk to this patient? So obviously they're coming because these lesions are bleeding, but that's one risk. But then we also have to make the patients and family aware that with the bleeding, there might be a risk of infection. If this is a large vein, this might be an added risk because there might be a clotting risk. And then in the future, we have to worry about orthopedic issues and also trying to get an even better diagnosis to think about some other things. And then we think about it as a team as far as what team members need to be available when this patient comes to our clinic. And so this is the start of us as vascular anomalists putting together what we think the diagnosis is. And the diagnosis has two components. It has what I call the phenotype, and the phenotype is what we see physically on our physical exam or even get a glimpse of with a picture. It's what we see on our radiologic evaluation and also our pathologic evaluation. So that's what I call the phenotype. And sometimes to make that final diagnosis, you do need a genotype. And the genotype is when we look and think about, is there a causative gene that's causing this problem? Could it be germline? There are some venous malformations that are germline, or sometimes patients that have something called P10, which is a tumor suppressor gene, but P10 patients can have P10 hamartoma tumor syndromes, and 30% of them can have vascular anomalies. So we think about that. But the most common causative genotype is a somatic mutation. And a somatic mutation is something called the body gene. So it's only in the area where you have the malformation. And we've heard a lot about that, and you'll be hearing more about that a little later on. And then as a vascular anomalist, we have to think of, is the genotype known? Do we need the genotype? And if we think we need it, how are we going to identify that? Because sometimes it's hard to get genetic testing for people who have somatic mutations. That is only in the somatic mutation is only present in the area where there is a vascular malformation. So do you need a biopsy? There's other techniques that we can look at the blood, or sometimes if someone has fluid, even in interventional radiology, we're starting for mostly research purposes now to look at something called circulating free DNA to find those answers. And hopefully in the near future, we'll be able to. But those are the things that we think about as a vascular anomaly team on how we make the diagnosis for a patient. What is the phenotype and what is the genotype? So you all know this is a diagram that I use, which is based on some work that Aaron Green did when I was in Boston. And I actually use this diagram to help explain to my patients, and I've given it to many other people, what their phenotype is and how it might relate to the genotype. So all on the outside are all of the phenotypes. So there's Klippel-Trenaunay, there's lymphatic malformations, there's something called fibroadipose anomalies, and they're linked to the causative gene. So that's PIK3CA, and then you find other things that are linked to causative genes. Because the majority of our patients fall into this area. You see venous malformations can be 20% PIK3CA or a little bit less than that probably. The majority of them are tied to. And then we know that there are other lymphatic malformations and other vascular anomalies that are over on this RASopathy side. We would love for this to be so entirely clear. So where someone comes in and they have a phenotype that specifically fits in this area. And when we have the phenotype and we try to look for the genotype, we get the genotype that we think it is. And that happens in the majority of people. but sometimes it doesn't happen that way. So sometimes we have a diagnosis that clearly fits over in this category, such as might fit over in the Klippel-Trenaunay category. But when we look our hardest for a somatic gene, we can't find one. And maybe that's because the percentage of those is so small in the area that we're looking at, or maybe it's because that phenotype might be associated with another genotype, such as TIE2. Sometimes we find things over here that we find a diagnosis here that we think is PIK3CA, and it's not, it winds up over here. And that's why it's so, so important for us to work as a team and to help you all feel comfortable with the diagnosis. But sometimes our brains hurt because we can't put them into nice separate boxes. The majority of time we can, but sometimes we can't. And when we can't, it's a group decision with you all to try to find out what the best phenotype is for a diagnosis, and then try to link it to the best genotype, because that's how we're going to find the best medications to treat a patient with. So going back to this patient does have a phenotype that fits into the PROS category, so PIK3CA related overgrowth spectrum, and the genotype is PIK3CA. And we talked a little bit about what happens to patients that don't really fit into this clean-cut category, and that happens in the rare circumstances. So going back to this diagram again, we're going to now branch off and we're going to talk a little bit about when you find a phenotype and when you find a genotype, what are the medicines that we can actually use to treat those patients. So back in the old days, so back 30 years ago, it was incredibly frustrating. I call it the chicken soup of medical management, because anything that was used for any kind of vascular anomaly, and most of the medicines were used for hemangiomas, were being used for vascular malformations. And when I was a young hematology oncology fellow, I just couldn't understand why. It didn't make sense to me. And I went out to the library and I tried to figure this all out. And that's where I found the importance of being together in a multidisciplinary center. We do know that because of one patient who we had an idea, a hypothesis that the mTOR pathway, so the bottom part of that PIK3CA pathway, was involved. We used this medicine to treat this patient, and this patient did incredibly well. And we've talked about this at other meetings. And this is where sirolimus, or the mTOR inhibitor sirolimus, came about. And that has been a godsend to all of us. So we know that sirolimus and other mTOR inhibitors like everolimus block this pathway, and this pathway is responsible for growth and differentiation. And when you're producing too much in this pathway, what happens is your body responds in a certain area with very immature vessels. So the wall might not be right, the cells might not be right, but they're very immature. And when I try to explain this to my patients, I tell them about a dressmaker. So I say, if you were a dressmaker and you made 5 dresses a day, and you made them perfectly, and your dresses were in every single high-end store in the world, and then your boss said to you, you have to make 25 dresses for me next week, those dresses would not be made the same. Their seams would not be right. Maybe a button would be missing. And that's what happens in this pathway when something is overactivated. It starts making things more immaturely. And so sirolimus has been shown to immature those abnormal vessels. And it's used in many vascular malformations. It's used in Klippel-Trenaunay. It's used in cloves. It's used in lymphatic malformations. We use it in some venous malformations. We also use it in some vascular tumors with great effects. We do know that there are some side effects to it. It is an immunosuppressive medicine. You can have mouth sores, headaches, GI complaints, some metabolic issues, like sometimes people can actually have increase in their glucose and their cholesterol. It can give you a tiny bit of anemia, and it can give you more serious side effects like inflammation of your lungs or effusions, though I've been very lucky that I haven't seen that in all of the years that I've been using it. It is FDA approved for transplant patients and also with tuberous sclerosis patients that have some vascular problems and also a disorder called LAM. And we're hoping in the next 6 months to a year to get it approved for our patients. So that's this part of the pathway. This is mTOR. And this came about, again, because of a hypothesis that this might have been involved. We did not have the information on somatic mutations when we thought about using this medicine. So we're going to march up this pathway because we have found some information with the somatic mutations, and we're going to talk about the drugs in the upper parts of this pathway. So the AKT inhibitors is one stop up above the sirolimus. The AKT inhibitor that some of you out there might be a part of the trial that happened a little bit ago or have information about it is miransartib. And so this is an AKT inhibitor that was used in breast cancers and also an overgrowth syndrome called Proteus syndrome. It's an oral medicine given once a day. The dose that's needed in our patients is 1/6 the dose that's needed in cancer. It does have, if you start looking at these side effects, they're the same kinds of side effects that you saw with the mTOR, mouth sores and headache and GI complaints. There was a study that was out there called the Mosaic study, which was looking at the efficacy and the safety of this in PROS patients, so those patients that had PIK3CA overgrowth. And there were several KT patients that were in that study as well as closed patients. In general, I felt that the side effects were actually pretty minimal. This drug, unfortunately, will not move any further. The people who are on it can remain on it, but it's not going to move further in clinical trials. But there are other AKT inhibitors that are out there that we're investigating for use. If you go up farther on that pathway, and I know we had Dr. Canode come and talk to us several years ago about the PIK3CA inhibitor alpelisib. This is what we call a selective inhibitor for the alpha part. So a lot of times these genes have different parts to them. So it inhibits one part of PIK3CA. It also is significantly responsible for metabolism and differentiation like all of these other drugs. And it first came out and was FDA approved for breast cancer, but in combination with other therapies. And that medicine was called Piqray. It recently has been approved because of retrospective, so that's information that we look at not in real time, but look at in sort of retrospectively. And it was FDA approved for PROS as a drug that they have labeled Vijoice. This is a conditional approval because they're doing another study now prospectively that I'm going to talk about in a minute. There also have been some case series of patients with venous malformations with TY2 mutations that have been on and have had very good results with this PIK3CA inhibitor. Some of the very same side effects as the other two medicines, but the two most significant are hyperglycemia and diarrhea. Though it can have skin side effects, mouth sores, you can get some thinning of your hair, some nausea, some increase in your lipids, pancreatitis, and other more significant skin issues. It is not as much of an immunosuppressive agent as sirolimus, and nor is the AKT inhibitor. So the studies that were available, so it started as something called a managed access protocol, where the drug company was giving the investigators the drug and was doing some of the regulatory issues. And that was the retrospective data that was used for the FDA to approve this. This MAP study was recently closed because it became FDA approved. So now people have to go to their pharmaceutical companies to obtain this drug. They're still looking at this retrospective review. They're looking at how people have done since that was closed to see about long-term issues. And there is something called a prospective study that is out there. This is something that we call a double-blind study. So in the first 4 months of this treatment, you have 2 people that are put on the drug to 1 person that is given a placebo. Also for this therapy, if people are on other medicines like sirolimus, they have to come off of their sirolimus for 4 weeks before they can start this study. And so this study is not necessarily for people who need alpelisib right now, because of you have to be off of your medicine for such a long period of time, and also because of the chance that you might have a placebo. But there are people who can wait and who have enrolled on this and who have done very, very well. There's 3 groups of patients and there's different starting doses. This was the initial reported paper that Dr. Cano did in France, where he looked at alpelisib and he found that there was significant response to it. It's not without side effects, as all of the other drugs are, and we went over some of those side effects, so just to point that out. I did want to tell you about the other side of this, circle, because it is important, because sometimes we can see people who have very large legs, who have almost like lymphedema or central conducting problems that might outside be diagnosed with something else. So might be diagnosed with PROS. But truly, when you look at their somatic mutations or even their radiology, might have a RASopathy versus a PIK3CA somatic mutation. And so these patients are treated a little bit differently than the patients that are on the right side of this diagram. And these are the type of patients that have RASopathy. So this is a patient that actually has an arterial venous malformation, and you can see that this progressed very significantly, even with interventional procedures and surgical procedures. And these are different types of lymphatic problems. This is something called caposiform lymphangiomatosis, which way back in the olden days was considered to possibly be a PIK3CA kind of disorder, but it winds up being a RASopathy. And this up above is a patient that initially was diagnosed as having possibly Klippel-Trenaunay syndrome, but winds up having bilateral significant lymphedema with a central conducting problem, meaning that they have very leaky lymphatics around the heart and also in the lung. And this is all abnormal lymphatic channels that you see throughout the abdomen, by the liver and the spleen, and also a very tortuous thoracic duct that you really shouldn't even be able to see. So these patients get treated with other things. They get treated with something called MEK inhibitors. And trametinib is the one that we use the most, though we are starting to use other agents. And these medicines have been used in skin cancers and other kinds of brain tumors. And they have some side effects related to skin, to the GI tract, like nausea, some cardiac issues, and some eye issues, particularly pertaining to the retina. We do have some other therapies that we are thinking of, which will be wonderful. This study was started, but unfortunately had to be closed for now. It definitely might reopen, but this is a study using a topical PIK3CA agent to treat venous and lymphatic malformations. And this is a study that's going on now. It's a topical sirolimus that the concentration is higher, and having some great responses to microcystic lymphatic malformations. These are vascular anomalies, and this is linking them to the genotype and to the potential treatments. And I'm more than happy to have anybody have these slides. And the whole purpose of our therapy is not so these therapies to me are biologic agents. They are not chemotherapies. Yes, they're used in cancer, but cancer is different. Cancer is a somatic mutation which has changed and has had perhaps what we call in the oncology world a double hit, second mutation that causes a cell to grow out of control. It's not as simple as that, but it's very, very different than what we're taking care of. So these medicines are used as biological agents. We do not need the dose of these medicines that's being used in cancer. Our goal is really to reduce, not eliminate. We know that many of these diseases are not going to go away, that we need to control the symptoms and the problems that we have until we find better medicines and better intervention. So we don't need something called the maximum tolerated dose, which is the higher dose. We need to treat patients chronically. We need to treat children and adults. And I always say to my oncology colleagues that cancer can learn from what we're doing with vascular anomalies. Just for you all to know, we have started a consortium. The PIs of the consortium are HEMONC members, but the co-PIs are anyone else who's part of your vascular anomaly program. And we're trying to bring people together so that when we get a new medicine, we can do it in the right way. We have 20 sites right now, and 2 patient support groups are also members, and the KT group, Melanie Finger, is a member of this consortium. And our aim is to improve clinical research for patients with vascular anomalies. We need many things, and I'm just you can read the rest, but I put this in my favorite color, purple. We need awareness. So we need the NIH to know who we are. We need the public to know who I am. And I'll tell you tomorrow some things that came about when I did a day in the life, and I was very upset with the awareness of the people in general. They need to be aware of rare diseases, and they need to be aware of what you all go through when you have rare diseases. So with that, I want to thank you. I want to thank the patients and the families, all of the patient support groups, particularly the KT support group. This is one of my favorite meetings, and I'm kind of sad that I'm missing it. I'm trying not to cry. My funding sources are listed, and I can't be where I am today without my institutional support. So thank you very much.